Hello, everyone, and welcome to today's webinar hosted by the Oregon Office of Rural Health. My name is Rondianne Gerst, and I'm the Rural Health Clinic Program Manager. The webinar you are attending today is titled Advanced RHC Cost Reporting, presented by Jo Raebel from Wipfli. Jo Raebel has more than 19 years of experience in audit and accounting services, focused exclusively on healthcare industry clients. She specializes in assisting freestanding and provider-based clinics to navigate through the rural health clinic certification process and is a proven thought leader with vast experience in the RHC arena. Jo helps to calculate RHC Medicare and Medicaid rates, provides education regarding changes in billing because of certification, and consults on all areas specific to RHCs. In addition, she helps organizations determine the best certification options to experience the most beneficial gain from Medicare and Medicaid reimbursement. Jo is a regular speaker at industry events and conferences such as the Rural Health Clinic Association of Washington, the Oregon Rural Health Conference, and the National Association of Rural Health Clinics Conference, just to name a few. Before we begin, I have a few housekeeping details. The webinar will be recorded. Eric Jordan will post the slides and recording on the Office of Rural Health website within the next few days. Thank you, Eric, who is our tech support during the webinar. If you encounter technology problems, enter your questions into the chat box and he will assist you. You are all currently muted and your video is off. Jo will be happy to answer any questions at any time during the presentation. Enter your question in the chat box and I will read your question out loud. I put a link to a survey in the chat box. Please complete that short survey by the end of the presentation so the Office of Rural Health can continue to provide resources most helpful to your RHC. Without further ado, Katie, the screen is yours.
Thank you. Thanks again for having me. Feels like we were just here. All right, well, we're going to be talking about advanced Medicare cost reporting topics today. And gosh, there's a myriad of issues that we could talk about. And we only have an hour, which is a short amount of time. But basically what I wanted to go over today is, just a brief overview again about the Rural Health Clinic cost report. I'm not sure if all of you were on last week or not. We'll talk about RHC visits and provider productivity and really dive into those a little bit more during this session. I also want to talk about RHC benchmarking. And then we briefly went over COVID-19 considerations, and I kind of want to dive into those a little bit deeper in this presentation and give that some extra time so you guys have questions. That's a hot topic, obviously, so I thought we would dive into that a little deeper today. Again, feel free to ask questions. I don't think we have a super large group. If you have questions as they come, feel free to answer them. I'll pause every once in a while and answer questions as you have them. So let's go over the cost report in general and again, go through a review of it. Why do we even have to prepare a rural health clinic cost report? Well, it's because once we go through the hoops of rural health clinic certification process, we have to make sure that we are reconciling to what we should have been paid throughout the year. We get paid based on a cost-based methodology of reimbursement, and that's for freestanding and provider-based, although freestanding, or oftentimes referred to as independent RHCs, have a cap. We have this cost-based payment, and we have to reconcile what were we paid during the year versus what should have we been paid. And we're going to either owe Medicare a little bit, or Medicare is going to owe us some, depending on how much we were paid during the year. And we have a couple other components of the rural health clinic settlement that go into the cost report as well. So again, we're talking about two different types of rural health clinics. We have independent or freestanding rural health clinics, and they submit their cost report independently. They aren't part of a hospital cost report. Even if they're owned and operated by a hospital, and that's possible, they have their own separate cost report. It's like a mini cost report. Provider-based rural health clinics, their cost report is actually embedded in the hospital's cost report. So it's a subsection of the hospital's cost report. It has its own provider number listed, its own department within the hospital cost report, and actually has its settlement listed separately in the hospital cost report section. So when you're talking with other rural health clinics, I really encourage you to talk to the same type of clinic. Are you provider-based or independent? And there's some big differences between the two. We know that that cost report is due typically 5 months after the close of the period that is covered, the cost reporting period. But we also know during the public health emergency, we've been getting extensions on those cost reports. So we do have some extensions. We have to file the cost reports electronically. And if we do have a change of ownership or another kind of, maybe we even terminate our RHC number, any change to our enrollment, if we have a change of ownership, a change from freestanding to provider-based, we have to settle up 150 days after the end of that period. So if we have a cost report that changed ownership, July 1st or July 1st, we would then have a cost report due 6 months after that 6/30 period. Typically, we don't get extensions to file, again, only in a pandemic or really, really extreme situations. I've seen one, and I think I mentioned this last week, a fire or a mail truck caught on fire, and that was the only other time that I saw an extension, but typically there are not extensions on the cost report. Our end game of the cost report is we want to get to the three components, and these are the three components that make up the cost report settlement. We have our all-inclusive encounter rate that we're trying to calculate, which then is compared to what was our interim rate during the year. So if our interim rate was $150 that we got paid based on by Medicare during the year, but our cost per visit on the year-end Medicare cost report calculates to be $200 per visit, we're going to have a receivable for that component of the cost report. The second part of the cost report is our Medicare flu and pneumonia vaccinations. So we get paid for those on the Medicare cost report at a cost per injection. And these are for direct Medicare patients only. And the third part is our Medicare bad debt. So we get paid 65 cents on the dollar for unpaid deductibles and coinsurance, for direct Medicare beneficiaries, for rural health clinic services. So those are our Part A services that we build. Under our RHC provider number, we can get paid for those. So we're going to dive into those a little bit deeper. But that really is the general overview of what we're trying to get to with the cost report. Those are the three components of the cost report. And those are really, three things that you really want to hone in on when you're reviewing your cost report and signing off on it. So this is, again, quick and dirty of the cost report all-inclusive encounter rate, right? This is component one. I went through what are the components of the cost report. When we met last week, we went through, okay, what makes up allowable costs? We start out with your trial balance. We move costs around either through reclassifications or we remove or add costs on through adjustments. And we get to this allowable cost in our numerator. And once we get to that allowable cost in our numerator, we then have to come up with our denominator, and our denominator being the greater of rural health clinic visits or productivity standard visits. And we're going to dive into that in a second as well. But this is our quick and dirty calculation. Notice that we don't report revenue. If you're part of a critical access hospital and maybe your clinic was a provider-based department before, we know that revenue was important in your cost-based calculation because you were paid based on a cost to charge ratio. What's different out of an RHC is, yes, you're paid based on cost, but it's not a cost to charge ratio, it's a cost per visit. In addition, you're getting paid for your professional component at cost, whereas in a provider-based clinic, like to a critical access hospital, we're getting paid based on fee schedule. So that's the real win. When you become a provider-based RHC from a provider-based clinic, you're no longer getting fee schedule reimbursement for your professional component or APCs if you're a part of a larger hospital. So again, we have our numerator of costs, we have our denominator of the greater of actual visits or productivity standard visits. That gets us our RHC cost per visit. And we know that there's certain reimbursement limits for independent RHCs and provider-based RHCs that are provider-based to hospitals with greater than 50 beds. We're also going to talk about the new regulations and law that was signed at the end of 2020 and what that could mean for those limits. So this is component one, right? We get to our interim, we have our interim rate compared to our actual cost per visit, and we may or may not have a settlement depending on what we were paid during the year. Component two, again, is our Medicare flu and pneumonia vaccinations. These are paid based on cost as well, but our cost is different. They're no longer considered part of our all-inclusive encounter rate. It's a separate cost per injection. So when you look at the cost report on the last page of your settlement, and I'll go through what pages of the cost report you may want to look at that has this information, you'll notice that there's total costs related to RHC services. And then under that, it actually subtracts out costs for flu and pneumonia vaccinations. And that's because those costs are not included as part of your all-inclusive encounter rate. You're getting paid separately for those through the Medicare cost reports. And that's why we don't bill these during the year. And believe it or not, I have clinics all the time that we find out, oh, they were billed to Part B, but we've also considered them for the cost report. And we're like, hold up, if you billed for these and got paid fee schedule, we also can't claim them on the cost report. So you want to make sure you're not getting paid doubly for them. But we don't want to bill them because, again, we're getting paid cost. And typically, anytime we're going to get paid cost over some fee-for-service amount, we're better off. And in order to do that, we have to create a log with the name of our patient, our Medicare number, our date of service, and we also have to support our costs that we come up with for the cost report. And that includes vaccine invoices that are submitted with the cost report. We may also provide a time study of how long it takes to perform the injection. Typically, we'll get an average amount from the clinics and the intermediaries accept that. And that's in order to come up with our staff time per injection. Keep in mind also our Prevnar vaccinations are also reimbursable as part of the cost report. So this is part of our pneumonia vaccination cost. And one thing that I recommend is splitting out, and I don't have this within the slides, but you might want to write this down. For your cost report preparer, you're actually in a much better position to come up with an accurate cost per injection, and typically it's more beneficial if you separate out your injections and you're tracking them by high dose flu and regular dose, and then your pneumo injections between the pneumo 13 and the pneumo 23. And that's so we can come up with an accurate cost per injection for our Medicare patients and make sure that we're assigning the cost per injection that way. So again, we're not billing for these. These are Medicare direct Medicare beneficiaries only. These are the only injections that are paid through the cost report. I get questions like this all the time. Well, aren't our vaccinations and all of our injections paid on the Medicare cost report? Well, they're part of your all-inclusive encounter rate, except for these. And if we have an injection-only type of visit, we're not going to be able to claim it on the cost report under some log like flu and pneumonia. It's part of your all-inclusive encounter rate, and we're not actually able to bill for that service unless they have a qualifying visit. And keep in mind, Medicare is only going to pay you one encounter rate, typically, regardless of the number of services. And what you're going to get from the patient is 20% of total charges. So that's really what you're gaining when you have a visit and an injection on the same day. You're not getting any more from Medicare, but what you are getting is 20% of total charges in the coinsurance calculation from the patient. So that was component 2 of the cost report. As a review, component 3 again is our Medicare bad debt. And I really like to go over this again because I have a lot of rural health clinics that just don't claim Medicare bad debt, or they're not tracking it and they don't think it's worth it. Medicare bad debt, if you see in your cost report you've been claiming none, or you still have amounts that you can write off, I really highly recommend that you go ahead and get them off your books and claim them on the cost report. At one time, Medicare bad debt was actually paid at 100% of the allowable bad debt, and I can't even remember what year it was reduced. It's been a while back, but it was reduced at one time to the 65% of the amount claimed. So you'll see on your cost report, there's a work paper in there, a worksheet that has the total amount of Medicare bad debt, but then the cost report actually reduces that to 65%. And that 65% of your total amount that you're claiming is what you're going to get back on your Medicare cost report. So let's review what constitutes Medicare bad debt. Again, these are unpaid deductibles and coinsurance for our Part A services only. So these are for our rural health clinic services. And let's revisit what doesn't constitute an RHC visit. Lab, right? Our lab services. So let's think about anything that was billed to Part B or would have been billed under the hospital is not considered RHC. It's not part of our inclusive encounter rate. We don't get paid under the RHC benefit. So lab services, if we're freestanding clinic, those are billed to Part B. Or if we're provider-based clinic, they're billed under the hospital's number. We don't get to claim those under our Medicare bad debt. It's not an RHC service. The same thing with the technical component of diagnostic services. Those are also billed either to Part B or under the hospital, and we don't get to claim those on the Medicare bad debt listings. And then any services that we perform in the hospital, those are not RHC services. Telehealth, no, those are paid under fee for service. Chronic care management, anything paid under fee for service, we're not going to be able to claim those on our Medicare cost report. And these do not pertain to Medicare Advantage patients. These are direct Medicare patients only. All right, so there's 3 different types of bad debt. The first being right down here. One type is the type that we've made a reasonable collection effort from the patient to collect on, and Medicare deems reasonable as 120 days from the date the initial bill was first sent to the patient. You've gone through your standard billing and collection policy with that patient. If the amounts are in collections, we cannot claim it. But if they're in collections for a while and we decide to take all patients back, regardless of payer type, under a certain amount at a certain day period, we can take those amounts back and actually include them on our cost report if we write them off completely. And that means all collection efforts have ceased. Oftentimes what it's a good idea to do is look at any amounts that are in with your collection agency and say, well, the majority of these items within this certain period are Medicare patients. If we take all the payers back during the certain bucket, we can then claim them on the cost report, write them off, be done, and get 65% on our Medicare bad debt that we claim on the cost report. The second type is if we have Medicaid as a secondary payer and they've made a denial that they're not going to pay any more on the claim, then we can write those off immediately on the cost report. Of course, there's no 120-day rule, but we do have to get the denial from Medicaid. And the third type is if we have a documented charity care policy that applies to all patients regardless of payer type, and that patient qualifies for charity care, we can also claim those amounts immediately on the cost report. This is information that has to be included with the cost report. And basically, this is Exhibit 2 that is submitted with your cost report. And I have this in an Excel file, but this is really the paper copy from CMS. I'm going to share oftentimes what we see. When we get a Medicare bad debt listing from a client, we see amounts in here that don't add up. So some problems that we see, deductibles and coinsurance here don't equal our total. We see the date first billed to beneficiary and the date the collection effort ceased. They're not being 120 days between the two, even if there's no Medicaid number and the patient didn't qualify for charity care. So then we kind of have to go line by line and make sure, okay, if they were not charity care and they did not have a Medicaid number, there should be 120 days between these amounts. And these are things that you get audited on. And if Medicare sees a ton of issues with your Medicare bad debt listing, they'll throw it out altogether. and it'll create an audit. So one, you want to make sure that all of this information is completed. That's the other thing. Oftentimes we'll just get patient name, Medicare beneficiary number, and our total write-off amount, but we don't have all of this information. Oftentimes what we'll say is, client, this is the information that's required. We can certainly submit it as is, but you're certain to get audited on it, and they're going to want the additional information, so have it ready. Best thing to do is just to be keeping track of this, maybe month to month, having some sort of system in order to track this, so you're not scrambling at the end of the cost reporting period to get this information together for your cost report prepare. So just some information there. If anyone needs the Excel spreadsheet, I can definitely get that to them as well. As a review, this is also the Medicare cost report worksheets where you'll find some key information relating to the cost report. We can see that our expense information, if we're an independent RHC, is on worksheet A, or A and M-1, which M-1 of our provider-based hospital cost report actually breaks those out a little bit further. You'll notice too, on worksheet A, there's columns for reclassifications and adjustments, and those come directly from these worksheets here, A6 and A8. We went over related party adjustments last week. Those come from A8-1. If you're a provider-based rural health clinic, you also have a portion of overhead that's allocated from the hospital to the RHC. And you can see those flow through the B worksheets, and their overhead allocation comes from B Part 1. But I'll mention that that actually is driven off of the statistics that are indicated in B-1. So you might just kind of want to write that down. We also have then visits, FTEs, that is all located on B Part 1 of our independent RHC cost report, or M-2. So this is where the greater of actual visits or productivity standard visits, you can see what's being used in the calculation. The flu and pneumonia cost per injection that I referred to earlier is on worksheet B-1 or M-4. And then we get to kind of the nitty-gritty. What's our actual settlement at the end of the cost reporting period? We can find our cost per visit here. We can find what our Medicare bad debt is that we're claiming on these worksheets. What's our final settlement? What your Medicare utilization was for the year, your Medicare visits. This is where your PSNR information is entered. All kind of the end result that we're trying to get to is on worksheet C and M-3 of the Medicare cost report. I'm going to pause there for a second and see if we have any questions thus far.
Nope, there are no questions at this time.
No questions. Okay. Okay. We know, once we get to allowable costs, a big component of the calculation is that denominator calculation. And that's why I want to revisit and kind of dive into further the RHC visits and provider productivity. So again, as a reminder, here's our quick and dirty calculation. And this RHC visit number here, again, is the greater of actual visits or productivity standard visits. So let's talk about visits first. We want to make sure that we're counting face-to-face medically necessary encounters with an RHC defined practitioner in an RHC setting, right? So one visit must be face-to-face, okay? And it's got to be with an RHC defined practitioner. And our RHC defined practitioners are listed here. Our physicians, PAs, nurse practitioner, certified nurse midwives. We also have our clinical psychologists and clinical social workers that are defined RHC practitioners. These are our RHC practitioners that can provide visits. You may have other provider types within your rural health clinic. For example, maybe you have an audiologist performing services. Maybe you have a dietitian. In a rural health clinic, those are not RHC defined practitioners. And if a patient came in and that was the only service that was performed on that day, we cannot bill for an encounter. Therefore, if we're counting those visits, we're actually increasing our denominator, which decreases our cost per visit. If we count too many visits, we're actually doing ourselves a disservice for our cost per visit calculation. Okay, so we want to make sure we're including face-to-face medically necessary encounters, and that means if a patient comes in and we have like a blood pressure check with a physician or an allergy injection, if it's not medically necessary for that provider to perform that type of service, we don't want to be counting it. And I'm sure that most of your providers are not doing, services like that. But again, it's got to be medically necessary that they perform the service. And 3, it's got to be with that RHC provider type. So really important for those individuals that are counting visits within your clinic for the cost report, we want to make sure that they know who our RHC practitioners are, which differ from the Medicaid, Oregon Medicaid's definition of an RHC practitioner. So keep that in mind. They actually have a larger scope when they're defining RHC practitioners. On the Medicare cost report, we want to be thinking about what would we be able to bill if this patient was a Medicare patient. Let's go back to this. I always get questions about this too. Well, this only includes Medicare allowable costs, right? So therefore, we only want to include Medicare visits. Wrong. We're including all of our costs. Therefore, we want to include all of our visits. And Medicare is usually your overall cost per visit when it comes to paying you for your Medicare visits. So we want to be counting all visits regardless of payer type. Also, all of our visits that take place should include visits within RHC hours of operation. So let's say you have non-RHC hours of operation. We don't want to include that because we should be carving out costs related to that. Home visits we want to be including. So really outside of the walls of the RHC, we can also bill for home visits, nursing home visits, which includes swing bed visits. Home visits also encompass assisted living. We want to be counting all of our RHC billable encounters, okay? But we don't want to be including are those visits that our RHC practitioners may be performing, but not necessarily in RHC type setting, like surgeries in the hospital, ER rounds, another rural health clinic setting that has a separate provider number, or another clinic that's not part of our RHC. Keep in mind that we are certified by address, and every rural health clinic has a separate provider number. So we really want to make sure that we're billing under that correct provider number. And I'm just saying this because it's happened before, and it's actually happened in the state of Oregon, where we did have a clinic that purchased another clinic and they thought they could just add on to their existing rural health clinic number and bill them out. So you want to make sure that you're counting your RHC visits by clinic. Nurse-only visits, we're not going to be counting. And again, I like to really remind you that counting of visits is easier said than done. We want to make sure that we're not just going through and printing off a report that said these are all the services that we provided, and we go to the end and we say, yep, that's our ending number. Because if we do that, we're counting our nurse-only visits. We may have diagnostic services and lab services that are included that we shouldn't be counting. We want to include, again, those face-to-face medically necessary visits with our RHC defined practitioners, which again are right here. So we have our visits, right, that we're comparing to then productivity standard visits. And our productivity standard visits hinge off of our FTEs. We want to make sure that we are counting FTEs for rural health clinic time only. So in the same token, if our actual visits are too high, or our FTEs are too high, we're going to dilute our cost per visit. So we really want to be able to pare down our FTE as much as we possibly can within reason, and we want to be able to support it. But a few things that we don't want to include are time outside of rural health clinics, so non-RHC setting, which I have down here, hospital time, right? Or let's say, again, we have time in one clinic and then time in RHC 2, or another clinic that's not RHC certified. We only want to include time that they're in RHC 1 and available to see patients. If they're also doing, again, hospital surgeries, or they're, over doing ER rounds, we want to make sure we're excluding that time and expense. Administrative time should also be excluded. Medical directorship in the hospital, that should also be excluded. We really want to be including those items up here. Time spent in the clinic available to see patients, and that would also include our charting time. time spent with our nursing facility patients and swing bed patients, we want to count that as well. One thing I'm just going to mention as while we're talking about swing bed patients, just kind of as an opportunity, we see a lot of critical access hospitals that have a swing bed program, but they're utilizing their hospitalists to perform the swing bed rounds. And the hospitalists, those rounds are not being billed out under our RHC. If we had an RHC practitioner performing those swing bed rounds, we could actually be getting the cost per visit for that visit, the professional component. There's nothing in the regulations that say our RHC practitioners have to be performing services within the RHC. How could we get the hospitalist costs for the time that they're performing swing bed visits in the RHC and the FTEs within the RHC so that we can bill them under the rural health clinic benefit? So kind of as a strategy, move your hospitalist costs for the time that they're performing those swing bed visits to your rural health clinic, ensure that their FTEs are counted properly, and bill those swing bed visits under your RHC provider number. So just kind of a strategy there. I'm getting lots of questions about that still. Provider time per visit, you'll see in the Medicare cost report where it says FTEs. It also has a line for providers not performing services on a regular basis. If they're not performing services on a regular basis, we don't have to include their FTEs. And the reason being is because most of the times these are locums that may have filled in for a provider where their FTEs are already included in the calculation. I like to give this example because oftentimes what we get are total FTEs based on a payroll report, and we have one full-time physician and they're there full-time, and we base our productivity standards off of one full-time FTE. But as we dive into things a little bit more, we discover there's a productivity standard problem. We're able then to carve out some of that time. We know that they provide services within the hospital, they have medical directorship time, and they have administrative time. Therefore, we really should only be reporting 0.7 FTEs for that provider. And again, remember, the more that we can pare down that FTE, the better off we are for our cost per visit calculation. This is just a reminder of those FTEs that are applicable that have never changed since the RHC program came to be in 1977. 4,200 visits annually for one FTE, 2,100 visits for our PAs, NPs, and certified nurse midwives. And this is a worksheet right from the Medicare cost report where we have our physician FTEs, which then drives our productivity standard visits. So our 3.5 FTEs here times our productivity standards gets us to our minimum visits of 14,700. And the same goes in this calculation. There's our 0.8 FTEs for our physician assistants, but their productivity standards are cut in half. So they only have 1,700 visits approximately that Medicare expects them to see. So in this case, we actually have total actual visits that are greater than our total productivity standard visits. So what's going to be used in the calculation of our cost per visit is the greater of these two. So Medicare is going to be using this 18,200 in the denominator to come up with our cost per visit. So as a cost report preparer, I'm asking, is this number correct? And that's where I would question, are we counting nurse visits or something else that we shouldn't be counting? And typically, we see this the other way around where we actually do have a productivity standard problem. Let's say like this example. So in this case, we probably asked, are you sure you're not counting some visits that shouldn't be counted? Are you counting nurse-only visits, etc.? We're able to whittle down our actual visits here. Our productivity standard visits are just a little bit more than actual visits. This is a number that's going to be used in our cost per visit calculation. In this case, what the difference this makes is a $10 per visit difference. And when you take $10 times what Medicare pays you on that $10, which is 80%. So, you know, $8 per visit times your Medicare utilization, that can add up. So on a provider-based cost report to a hospital with less than 50 beds, you know, again, that's $10 per visit times 80% times your Medicare utilization. That can be a lot. If we're a freestanding RHC, though, we're capped at a rate right now of like $88. This doesn't make a difference. But we're going to talk about where things are going, where things are headed on 4/1. So at the end of December, we know that the president signed into law the COVID relief bill, and part of that bill includes an increase in reimbursement for freestanding RHCs, which is awesome, and we're super happy that that's gone through. But we also know that provider-based RHCs are being affected a little bit negatively. So what this includes is a new cap for independent RHCs, and this will also be applicable to provider-based RHCs that are newly certified. And this cap is going to be slowly increased over 8 years. So we have a $100 cap starting in April 1st of 2021, and that's going to slowly increase over the next, actually 7 years. In 2028, then it increases to 190, and I'll show you the increase here on the next slide. Again, these limitations are going to apply to all RHCs, so both independent and independent RHCs that have been, you know, certified, newly certified, or in existence. The cap is going to be raised. Provider-based RHCs that are newly certified, and we'll define newly certified, will be affected by this cap as well, and that's both provider-based to hospitals less than 50 beds, like critical access hospitals, or provider-based to hospitals with more than 50 beds. They will have the same cap. Now, the language does indicate that existing provider-based RHCs will have this like grandfathered base rate that's going to be indexed annually by what's called the Medicare Economic Index. And currently that Medicare Economic Index is being used, or has been used for years, to increase the freestanding rate. And this is also the same index that Oregon Medicaid uses in order to inflate your Oregon RHC PPS rate, that MEI. So this is the current cap right now for freestanding RHCs and RHCs that are provider-based to a hospital with more than 50 beds. On April 1st, that cap goes up to $100 per visit, and then over the next 7 years, that amount is increased to $190. After that, in 2028, then in 2029, that 190 will be indexed forward by that Medicare Economic Index, which is like, it's been hovering about 1.8, 1.9% per year. It's a really, really small amount. And again, this is for freestanding RHCs and for newly certified provider-based RHCs. And this new is what we're trying to get some clarification on. I'll talk about that in a second. So for existing or grandfathered provider-based RHCs, the current law indicates that existing RHCs are those that were certified prior to 12/31 of 2019. If you had an RHC that was certified prior to that date, your base rate would be based off of, and this is also kind of an unknown, it's going to be based off of some 2020 rate. And we don't know if that's the 2020 rate that you were paid, or if it's based off of your 2020 cost report, because we know there can be significant changes between your interim rate and your actual cost per visit. So this is something that Medicare is going to have to interpret prior to 4/1. So we're anticipating sometime next month, CMS is going to interpret the law, and we'll have some more information regarding this. What we do know, we'll talk about productivity standards that may be waived in 2020 that could increase your rate. We'll talk about that too. But again, it's based off of this 2020 rate. NARC's interpretation and what they have, so this is a National Association of Rural Health Clinics, their interpretation based on their discussions with CMS is, let's say you have a base rate of $250, and in the next year, so your next year cost report ends up that your actual cost per visit calculates to be $230. $230 is going to be the rate that is going to be in effect for the next year. So basically, if you fall below your base rate, it's going to be the lesser of the two. Your base rate, that $250 plus the Medicare Economic Index, will be used going forward. So 2021, $250, 2022, $250 plus MEI is what's going to be used for the next year's rate. But again, if your rate per visit actually calculates to be less than $250, the lesser of the two is going to be used for that year, and you're going to owe Medicare back some money. So important thing on your cost per visit, and why productivity standards are still very important, is we're still going to have to go through this calculation every year. We may have a base rate, but if based on NARC's interpretation, we're still going to have a cost report to complete. This isn't a prospective rate that, oh, we have a base rate and it's going to be inflated forward. If we're not meeting that rate, we're going to get the lesser of two. So this cost report calculation is still going to be very, very important. For you freestanding RHCs, keep in mind, a lot of you have not had to worry about whether or not you're meeting, $100 per visit. Maybe some of you are just above this $88 per visit. What happens in 4-1 if you start getting paid $100 per visit, but we find out at the end of the year that you actually were like $88 per visit, you're going to owe some money back to Medicare. So that's an important thing. We also need to be looking at for freestanding RHCs, what was your cost per visit back in 2020 that you were getting paid, and what does your cost report look like? Are you making that $100 per visit amount? And if not, what can we do to get you over that cost per visit? So things get a little bit more important for our provider-based RHCs, or sorry, for our freestanding RHCs than they were in the past. And again, look at this increase over the next 7 years where we get to 190. I mean, have a lot of freestanding RHCs that are not meeting that 190 right now. Is that okay? We go and try to really increase our rate and spend more dollars, see less patients. So that's not what I'm saying, but we need to be mindful of these rates so that we are meeting them if we justifiably can. And again, FTEs are going to become more important for tracking for freestanding RHCs than they were in the past. Those visit counts are going to become more important because likely there's going to be an effect on your cost per visit, where before most of my freestanding RHCs were meeting the cap already. Any questions so far?
Yes.
Okay.
Let me see. If a patient comes into the clinic for hydration with the RN, is that a billable service?
So if we're talking Medicare, if that's the only service that was performed, it is not an RHC service because you had a nurse-only visit. If we had a visit with a provider and had a hydration, then the charges would be bundled on the UB, right? And we're going to get 20% of the total charges from the patient. We're going to get 80% of our interim rate, regardless of the number of services. Just because we had a hydration service, we're not going to get paid any more from Medicare. On the Medicaid side, if it's an allowable service that we can bill for, RNs are considered RHC providers, and you might be able to get your cost per visit for that service.
Okay, so to reconcile the provider FTE, do you include vacation time, PTO?
Good question. So if you look at the regulations from a long time ago, and I can't even find this before, when they were using the productivity standards and coming up with them, I mean, like I said, you can't even find it in the language that's out there now, but it says that the productivity standards were based off of all their time, including vacation. But I have had intermediaries, including Noridian, that have said, yes, you can exclude vacation time. If you get into an issue with a productivity standard issue, I would exclude your vacation time because the intermediaries have said exclude it. And let them audit it, let them decide if they need to add it back on. But I've seen them through desk review say remove it.
Okay. Can you define administrative time? And how about when providers are completing patient charts?
Yep, patient chart is considered patient related, so we do want to include that. But administrative time, I mean, believe it or not, I have a lot of practitioners that are doing a ton of work in their clinic, just administrative stuff where they're not available to see patients. I mean, I have a practitioner that I can think about just off the top of my head that is helping with billing. He's doing a ton of, just like I said, admin time that is not related to patient care, simply running the business of the clinic itself, and not available to see patients.
Okay, thanks, Katie. That's all for now.
Okay. On the question of our Oregon Medicaid rate and how this new law may affect your PPS rate, the state of Oregon would have to do a state plan amendment to change how you're currently getting paid. I don't see that being affected right now. I'm not anticipating that. So I think we can expect that your Oregon Medicaid RHC rates are going to continue just as they are now. So keep in mind, even if you are certifying a new rural health clinic, I see this for freestanding RHCs. They may lose on the Medicare side, but depending on what their payer mix is, if your Oregon Medicaid rate is high and you can get a high enough cost per visit, it still is an overall gain on the RHC side. So don't count it out like, oh, rural health clinics doesn't make sense anymore. Well, you have to look at your payer mix, the types of services you're providing. And again, if you're highly Medicaid and you're getting paid under fee-for-service right now, when we have an average of like 120, 130 and upwards of $300 per visit for Oregon Medicaid RHC services, you're likely to have a gain on the RHC program. So I just don't count the RHC program out. There definitely still is a win.
Katie?
Yes.
What are your thoughts on OHA following Medicare's new payment?
Yeah, and that's what I don't think they will. But they would have to go through the state plan amendment. Will they eventually? They could, but I don't, there's been no talk about that at all. So I would assume that we're going to get paid our full cost-based reimbursement for now. Note also that Oregon Medicaid does not utilize productivity standards when they calculate or when they look at your rate that you sent over for Medicaid RHC rate. But what they do is they look at productivity standard visits compared to your actual visits. And if there is a big difference between the two, they're going to ask a lot of questions and it's going to be drug out for a while and it's going to take a while to get your rate. So you want to be prepared to discuss if you have big productivity standard issues in your clinic. Again, they're not going to use the greater of the two. They're going to use actual visits, but you want to make sure that you're able to support those numbers. And this Medicaid rate is really important, how you set it, because it truly is a prospective rate. Once you get it, it's set, and it's inflated yearly by that Medicare Economic Index. And unless you have a qualifying change in scope that increases your rate by a certain amount, you're stuck with that rate. Okay, Medicare vaccine reimbursement. We talked about flu and pneumonia, and I believe I mentioned this last week, but I wanted to put them in the slides. CMS has also indicated that the COVID-19 vaccine administrations for Medicare, and this is key, Medicare Advantage payment patients are going to be treated just like flu and pneumonia vaccinations on your Medicare cost report. So we want to make sure that we're not billing for these services out of our RHC, and that we're keeping track of those patients. I anticipate that we're going to have to submit a log just like flu and pneumonia if we're going to claim them on the cost report. So again, Medicare and Medicare Advantage for COVID-19 vaccine administrations, and we're going to get paid for the administration on the Medicare cost report. One benefit of this is, like, let's say, well, we might bill them out of the hospital. If you bill them out of the hospital, yes, you can perform roster billing, but you're still having to bill for it and chase that. And this way you don't have to bill for it, which takes some burden off of your billers, at least for your Medicare and Medicare Advantage patients, which are probably the majority of the patients that you're providing these to right now. And if you can get reimbursed at the end of the year on the cost report, it's probably going to make it easier. Keep in mind, these are the only injections, again, that are reimbursed through the cost report, is flu and pneumonia and your COVID-19 administrations. What we, again, want to make sure of is that we're tracking this. And we need to we're going to have to come up with some staff time. How long is your staff spending per injection? Another important part of this, and I'm getting a lot of questions on as well, it's not necessarily all of our RHC staff that are performing these injections. Well, what we need to do is move the staff time over to the cost report so then it can be part of your calculation for those injections. So they may not be part of your RHC. That's okay. It's really a cost reporting function. We just need to make sure that we move over their salaries and benefits to the RHC when they're performing those services, and move them to the rural health clinic. So where are your costs? We got to track these services. We're going to have to keep a log. Can you automate anything? What can you be doing to make this easier for the cost report at the end of the year? This is just the flu pneumonia reimbursement calculation. We're probably going to have another column we did during H1N1. We'll probably have one for COVID administration here. And our end game here is coming up with a cost per injection for our different types of injections. This number times the number of Medicare injections gets us to the amount that we're getting reimbursed on the cost report. And this is from the Medicare cost report worksheet B-1 and M-4 that we can actually then follow through. You can actually see it following through to your reimbursement calculation. Whew, 8 minutes. Okay. I wanted to include some information regarding benchmarking report for independent and provider-based RHCs. We have teamed up with NARC in the past to provide benchmarking services for rural health clinics. And so if you're a NARC member, if you're a Wipfli client, this is some information that you can get specific to your clinic. But you can also just look on here on the information that I provided that has some valuable information that you just might want to look at. Okay, where do I line up with other rural health clinics within Oregon, within the Western region, and then nationally? Information, here, encounters per FTE by provider type. And this is by cost reporting year. Now, I will mention this information is as good as the cost report that was completed, because this is right from CMS's website. It's called the HCRAS data. We download the information from CMS and we're able to extrapolate the information and organize it. But this doesn't mean that the cost report's correct. So, it's as good as the cost report that's being filed, and I can tell you there are some cost reports that are incorrectly filed, but there's still some good information on here. So I have benchmarking for both independent RHCs here, and then for provider-based RHCs here. You'll get these slides and have access to them, and you can look through your cost report and get some valuable data there. And if you have questions about it, I'm happy to answer any questions that you might have. I had these on the slides before, but I did want to, again, just revisit these, and just in case you weren't on the call last week, during the pandemic, we've had the ability to bill for distant site services as rural health clinic services, but keep in mind that those services are paid at fee schedule. We get $92 for telehealth and virtual visits. We get $26. We bill them on the clinic's UB, but they're paid at fee schedule. And we have to make sure that we're keeping track of the costs for those services and report them separately on your cost report. So you're going to want to be thinking about that. Where are the costs on your general ledger for those services? You might have to allocate some time to your providers. This is a question that your cost report preparer is going to be asking. So know that we have to carve those expenses out, and there's some information here for those. Visiting nurse services. Under the public health emergency, we are able to bill these services without having a home health shortage area designation. If you didn't know that during, just outside of the pandemic, you have to have a home health area shortage designation in order to bill these. But during the public health emergency, you can actually provide these services and get paid under your all-inclusive encounter rate. What we have to make sure of is if you are providing these services and you weren't providing them in the past, you need to let your cost report preparer know, and we need to be counting these visits in your rural health clinic encounter rate. We also know that these productivity standards, a lot of RHCs are getting productivity standard exceptions approved by the Medicare intermediary due to COVID. And if you haven't requested one and you've had a productivity standard issue in the past, you probably want to think about that. Contact your cost report preparer. They can help you get something to the intermediary and get something quickly from them. They've been granting them. However, I will caution you that what it indicates when you get the approval is that it'll be reviewed during the desk audit. So just because you got the exception request granted, it doesn't mean that they're going to totally get rid of the productivity standard exceptions or productivity standards altogether. They may reduce them during the desk audit. So a couple things to be careful are, let's say this increases your interim rate by a ton, and then the next year you owe a bunch of money back because you have assumed you're going to get that entire productivity standard exception request. Also on your Medicare cost report, maybe this creates a big receivable for your rural health clinic, especially for provider-based RHCs. Again, maybe during the desk audit, that'll be cut in half because they didn't allow all of the productivity standards to just be zeroed out. So, you want to be thinking about that. And what are the ramifications if the exceptions when getting reviewed during desk audit are either reversed or they're just reduced. So there's some information here. We have 3 minutes left. Again, this information is in the slides. I thought I'd give a couple minutes for questions. Rondianne, do we have any?
Nope, there are no questions.
Oh, wow.
At this time.
Okay. Well, again, I am here. This is my contact information. Feel free to call, to email me if you have any questions. Obviously, again, there's lots of complex things with the cost report. If there's something that I didn't touch on today that you want to discuss, feel free to reach out to me. I'd be happy to discuss it with you. Those are, I think, the things that I think are pretty important, especially for this year with COVID. But again, lots of changes to RHCs, lots of things to be thinking about, and feel free to reach out as you have questions.
Thank you, Katie.
Mm-hmm.
So appreciate your presentation today. As a reminder, Katie will be back with us next month, March 17th around 10, and we're going to discuss the new RHC payment rule changes. Thank you everyone for attending. There's also a link to a survey in the chat box. If you would please complete the survey, that would be wonderful. And again, thanks, Katie. You always provide so much wonderful information.
Thank you.